and welcome to the Brain Development Podcast. We're here to show parents there is a pathway to healing the behavioural and learning symptoms of their neurodiverse child. And my purpose is to help empower parents to understand how they can build their child's brain and body from the bottom up to invoke change. And today we have a very special guest, Yulli Tamayo-Myerson. She runs the Myofacial Clinic in Harley Street, and I have been to see her and her team with my son, and I know that so many parents have questions around tongue positioning and breathing, particularly mouth breathing, and that's why I wanted her to join me on the podcast. And she's using Myofascial release and cranial sacral therapy to address a range of physical challenges that some of these children and adults actually have. And she specialises in treating issues related to maternal and infant health, including complications from birth traumas and newborns. But Yulli's practice really focuses on the common infant issues such as feeding difficulties, torticollis, which is a twisted neck, and addressing fascial restrictions that may impact movement and overall development. So it's absolutely fascinating to have her here with us today. And her work is dedicated to promoting optimal physical function and well-being for parents and children. So thank you for joining me today.
Thank you, Lara, for having me.
It would be great to understand how you got into this work, and also, tell me a bit about the children that you see in clinic and how you take them on a journey to heal over a period of time so that they can actually have a better, you can explain it, but better jaw alignment for the development of them as they go through their whole life.
Sure. I'll tell you a little bit about myself and my clinic first. My background is in bodywork. Initially, I trained as a body worker, and then I moved to the UK and I entered the world of dentistry. And what I do now, I didn't learn in dentistry. It came up after. I did about 25 to 30 years of dentistry as a dental hygienist and therapist towards the end. And it was with my son then that I discovered orofacial myofunctional therapy. And I'll tell you a little bit more about myofunctional therapy in a second, but the reason why I entered that world was because my son was diagnosed with ADHD and he was being offered medication. And he told me that he couldn't get along with the medication, that he was changing his personality. So in a quest to find out exactly what was going on, because I had a child at home that didn't meet that criteria, when he was at home, he was very much in tune, very concentrated, and he was able to perform tasks. And then at school, he was overwhelmed by everything. And I came across a article by a myofunctional therapist in America that talked about sleep disorders or breathing disorders that affected sleep. And that's how I started going into this huge rabbit hole of breathing disorders and behavior changes that were caused by these breathing disorders. I found out that the snoring and the oversleeping time that he was spending and the difficulties waking him up were actually caused by the fact that he couldn't breathe properly throughout the night. And it was fascinating to me. When I started researching more and more in the topic, I found out that many of these children that couldn't sleep properly at night were actually sporting behaviors of ADHD and ASD. So that's how the whole thing started. And then my inquisitive mind, I wanted to know the root cause of it. So why is it not sleeping properly? Why is it not breathing properly? And what is stopping him from getting that full restful sleep? And it turned out that he had a tongue tie. I now don't call them tongue ties, I call them frenulum alterations, just basically because there are so many different presentations. And I have found also that many clinicians don't actually know how to assess properly these restrictions and these alterations. And basically what happens is when the tongue is not able to perform the job that it's supposed to do, not just for chewing, swallowing, and speech, but also for resting postures, good resting posture of the tongue, that when we fall asleep and all the muscles in our body fall asleep too, the tongue can actually obstruct the airway partially or completely. And that can cause a variation of symptoms from heavy breathing to snoring to apneas. And some people are more susceptible or they are more affected by these partial or full obstructions of the airway. And the brain can recognize the lack of oxygen when we are sleeping. And what it does is to preserve our or safeguard us, it partially wakes us up or completely wakes us up during the night. And what was happening to my son was that he was partially waking up. So what I thought was a full sleep or quantity of the sleep wasn't actually a good quality of sleep. He was fidgety, he was moving a lot in bed, he was snoring sometimes, and I didn't know. So when I took him to be assessed by the school ordered an assessment of him, not just hearing assessment, but also the cognitive assessment that they do for ADHD. And I found out that they were not doing all these checks on breathing. They were not doing checks on sleep. They actually found it quite amazing that I was actually requesting a sleep study. Did you check the sleep? Did you check the airway? And they were, no, what has it got to do with anything? And I ended up taking him away from the clinic completely and treating him for myofunctional disorders instead. So I went through lots of training because in the UK we had nobody
very
at that
few
point.
people. Yeah.
Very few people. So I set up the first clinic in myofunctional therapy, and within a year I set up the society for myofunctional therapy. And myofunctional therapy it differs from myofascial therapy in a sense that myofascial therapy is manual release of tissues to increase range of motion and to reduce tension. Myofunctional therapy is the repatterning and the re-education of the muscles that support
There's
the
a whole
orofacial.
lot more.
It's a lot more. So what we do in our clinic is we do a bit of myofascial work by opening up the fascia, elongating the muscles that have been affected by dysfunction, and then we tone them up and repattern the functions of those muscles so they can support the orofacial structure properly. Now, the tongue is a really misunderstood organ. A lot of people call it a muscle, and it's not a muscle. It's an organ with 16 muscles in total. There are 8 bilateral muscles either side of the tongue, and 4 of those 8 muscles are on the outer part, so they're extrinsic, and 4 of those muscles are intrinsic within the tongue itself. And they have a very complex functions, and together they have to work really hard in synchrony to be able to perform for speech, for swallowing, for chewing, and for resting postures of the tongue. And it's something that I don't think a lot of clinicians take into account. It's not taken into account all the time in dentistry, and it's not taken all the time into account in just normal functioning of for speech and for posture or for even swallowing and feeding. So as you correctly say, we are not paying enough attention to what the tongue has to be doing in order to help us perform those functions. The tongue is like an octopus leg. That's how I explain it to patients. It's actually a hydrostat. So a hydrostat is an organ or an organ that lives in wet environments, like the octopus leg will live in the sea and will stick itself and suction itself to rocks. Our tongues lives in a wet environment, and it has the capability of suctioning itself to the hard palate. When it doesn't do that, it doesn't perform one of the vital functions of the hydrostat organ, which is to act like a scaffolding mechanism for the structure, for the bones that are developing around it. And in our case is the upper palate. So the upper arch is really guided by the tongue during growth and development. And it does that by sitting on the roof of the mouth. So if it doesn't do that, then the upper arch collapses on itself.
So then you have problems with jaw, and as you get older, you then have to have braces, and you're still not getting great sleep because your tongue isn't sitting in the right position and could be causing sleep apnea your whole life. Yeah.
Exactly. It could be causing an obstruction of the airway when you fall asleep. So I actually have a model here, which we can demonstrate a little bit. So the tongue has to sit. I mean, it's a really large organ. As you can see, it's roughly the size of one's fist. And the airway is just that pipe behind there. So if we are upright against gravity and the tongue doesn't suck itself up to the roof of the mouth, it sits low. And two things can happen. One is the weight of it will end up propping the mouth open, which will encourage mouth breathing. Or the other thing, if you're very conscious about your mouth not being open, then the bulk of this will obstruct partially the airway as it sits low. It has to go somewhere. So we end up bringing our heads forward or bringing the jaw forward. So that has a chain of effect in the entire posture. So we see children that either have an open mouth posture and they become mouth breathers, or they have their lips closed with the jaw hanging loose, the chin goes back, and the head goes forward. And it's almost impossible to change or to tell a child to sit up straight if their tongue is low, because weight of fat will not allow it to happen. And our own survivor mechanism to preserve ourselves will force us to bring the head forward to clear the airway. So in that in that sense, it's really important that we understand what is it that is happening with what we're seeing outside. And a lot of the time we can see little red flags or cues of what may be going on inside without the mouth being open. Is the jaw hanging loose and back? Is the mouth open? Is the head forward? Are they sleeping properly? If they're not sleeping the whole night, or they're sleeping too much, or they're fidgeting a lot. When the mouth is open, also we lose oxygen to our organs. So a lot of these children will be sporting bedwetting as the systems go through a fight or flight mode all the time at night. And then, as we were discussing during our chat about your son before, it could also change the way we swallow and how we process food. And one of the things that I don't think is also, or is also ignored a lot, is the function of the tongue and the movement of the tongue when we're swallowing, which is the beginning of that wave pattern that the entire digestive system has to have in order to function properly. So it's a huge rabbit hole.
It is. And, what's really interesting is that you can go through a process, and it takes commitment. It takes, changing patterns, so you need to do them daily or multiple times a day, but there is a possibility to actually change the function, change the posture, and retrain the brain and the tongue and the body to actually change that trajectory of how that child holds themselves. And when you're not holding yourself in the right way, it can have many other implications. You may not run properly. You may end up with injuries as you go through life. You may end up with back problems, knee problems, hip problems, because you're not holding yourself in the right way and able to hold your head up, because your tongue is effectively so heavy that you end up, your frontal lobes come down and your tongue just starts to fall. So Talk me through what you do in assessing and getting parents to understand, because they're going to be listening to this and want to understand what are those things that you'd be looking for, because parents know their children as they know them, rather than are there some specific things that we should, other than mouth breathing, is there any other things that they could look for? And obviously posture's one, but then how do you help assess them and that process of healing that you go through?
So we look at, for parents out there, I think the best thing to learn is to identify the red flags. Okay, so I'll give you a few red flags, and then if those red flags are there, my advice would be to go and search for a myofunctional therapist who can do a full myofunctional assessment, because there are a lot of things behind those red flags that need to be also assessed. So one of them will be, are they waking up in the morning groggy despite long hours of sleep? So that will tell us that their sleep has quantity but not quality. They're not perhaps going through all the cycles of sleep. The other one is, are the mouth breathing during the day? And do you have an opportunity to check at night whether they have an open mouth posture, whether they're breathing through the mouth? Is there snoring? Snoring, despite a lot of videos out there that seem to portray baby snoring as cute, it's a bad thing. Snoring is not good for any age and is a big red flag. Are they grinding the teeth at night? So if they're grinding their teeth at night, is also a big red flag. It means that they are trying to open their airway probably at night too, and that they are actually trying to survive at night. So it's really difficult to sleep when the when the tongue is actually clogging or obstructing your airway. So the brain goes through a process of almost self-resus, where the jaw comes forward. You get a little bit of sleep as you get the air through. You fall asleep. Your muscles fall asleep with you, and so does the tongue. And then the whole thing collapses back. Then this nervous system goes into fight or flight mode. You clench because you're stressed or your body's stressed. Then there's a little bit of lack of oxygen. The brain goes, wake up, or partially wake up, bring the jaw forward, you bring the jaw forward. And that's the grinding that you...
That's the motion.
So it's the motion of trying to keep the airway clear. So that's grinding is important. Forward head posture is a big telling one as well. So yes, devices do exacerbate things, and looking at your phone and hunching over things do make it worse. But to me, a forward head posture is another red flag too, and to many of the people who work in this field will also look at it as a red flag. Is there a wearing of the teeth? So look at your child's mouth. Teeth should not be totally flat and even. The canine should have a peak, and they shouldn't be all the same length or reducing height. So that's another tell sign. Hyperactivity during the day. Yes, there is sleep ADHD and ASD as conditions. They exist, but we need to be also mindful of whether the sleep deprivation is actually causing them to also be hyperactive during the day. Adults behave differently. When we are lacking sleep, we reach out for sugar, for caffeine, for other things that keep our energy up. Children tend to become either hyperactive or withdrawn completely because they are overtired. So that's another thing. And their capability of self-regulation lowers massively if they're not having a restful sleep too. So that's another sign. Now, if you look at the structure, we look for a high palate. So is the palate vaulted, or is it nice and flat and like an U shape? If it is a V shape, there is also an issue. There is already an issue there, and the tongue is not sitting there during growth and development.
And
Yeah.
in terms of, you talk to me about as the mouth's open, you actually take in more more oxygen, more air when you're chewing, because you're not actually closing your mouth. And so therefore that then goes down into your gut and can also add to gut dysbiosis as well.
Yeah, so when the tongue cannot perform that wave motion, pressing against the palate as we try and swallow and propel the food from the front of the mouth to the back of the throat, it has to do that wave. So I tell my patients, if you do a wave like that with your hand, it goes all the way up, right? But if you hold that arm here and you try and do a wave,
Yeah.
you can't. You almost go forward and back. So that forward and back dysfunctional swallow collects
Right.
air, additional air. And in order for you not to spill your food out, the cheeks have to press in, which will be distorting the arches, the dental arches more. But you're also swallowing that additional air. If it's a baby doing that because the tongue is restricted or because the swallowing pattern is dysfunctional, then those bubbles of air are very big for the tiny digestive system. It goes down into the digestive system, brings up acid, the natural acid of the stomach, with additional acid. It's not something that we have to reduce with PPIs or anything like that, with the different medications. Is the bubble that is bringing that acid back up. And it happens in adults too. So that already dysregulates some of the functions of the digestive system. But that additional air that we absorb through the mouth changes the microbiome in the oral cavity. And the oral cavity microbiome is closely connected to the gut microbiome. So there you have a dysbiosis of both environments. And we see a lot of, in our patients, in an adult population especially, we see leaky gut, we see SIBO, we see Crohn's, and we see a lot of IBS. It's not a cure, but certainly improving that swallowing pattern will help with that accumulation of air, that bloating and all of that we encounter with these cases.
And you also treat and really look at vagus and cranial nerves as well, because I mean, in clinic I see exactly this. When you look inside a child's mouth, you don't actually see a perfect U. One side of the mouth might be down, and what that tells me and other functional neurologist practitioners that I know, that I've learnt from, is that their vagus nerve isn't active enough and that side of the brain is weaker. And so, and we also treat the cranial nerves as well, to stimulate them with either vibration or with a pulsing stim pod we use, which then helps activate those cranial nerves. So how do you do it in clinic as well? What do you do for the vagus and cranial nerves?
So ideally, your own body will be doing that
Ideally,
stimulation.
yeah.
Ideally. When the tongue has, the posterior fibers of the tongue have connections to stimulate the vagus nerve bilaterally. If the tongue is restricted in that swallowing pattern, it's going to be restricted not just for the swallow, but also for the movement of the bolus in all directions. And the chewing mechanism is also going to be disrupted. And all of those swallowing, moving of the tongue, and chewing are natural stimulators of the vagus nerve. So we see a lot of what you're describing there in our patients with restrictions of the tongue. They have a uvula, that little dangling bit at the back, is lopsided, or that U shape that you're talking about is not an U shape, it's lopsided. The tongue is sitting inside the mouth, lopsided. So that's how we begin to find out. First, we need to find out what is it, what is the root cause? Why is the body not stimulating the vagus nerve within the orofacial structure as it should? What is lacking? So more often than not, we find that the tongue has some form of restriction. It can be a tongue tie. It can be that the had trauma during birth. So this is why we've taken in a detailed birth history as well. Were they born by forceps? Were they born natural C-section? Or were there any, sometimes we go as far during the consultation as asking, were there any traumas during pregnancy, like whiplash or something that would have caused the mother to be very stressed during conception or during that period of pregnancy? And then the way we treat it is we stimulate the cranial nerves through different ways, usually through movement of the tongue, improving the functions of the tongue, removing, recognizing and removing those restrictions of the tongue so it can perform its functions properly. And we initially wake up the face. So we do that with several movements with cotton buds and, stimulating the intraoral cavity with cotton buds. And then once the restriction is recognized and is being treated, then we begin by expanding the fascia, elongating the muscles, retraining the functions, so the tongue can then become the natural stimulator of the vagus nerve in that way. If the tongue doesn't work properly, then those connections that go up to the ear and go up back to the neck as well are restricted. So we see a lot of issues with the vestibular system, balance issues, and even dizziness, people feeling a little bit dizzy sometimes, or getting overwhelmed with stress or with sensory input. They get overwhelmed and then they feel a little bit out of balance. And which are all things that I see in my special needs population too.
I mean, it's so fascinating. You're definitely going to be part of the healing path that I put these parents on, because this is such an incredibly important part of a child's healing journey. And that whole tongue posture and mouth breathing is known, but so many parents just don't know what to do or who to go see. So understanding that, what does it look like if a parent, with a 5-year-old wanted to go through this process? What would they specifically do with their 5-year-old at home? Because you take them through a process over, I don't know, 6, 9, 12 months. And how do you work with them?
So the therapy or the programs look different for each age group. If we're treating infants up to the age of 2, we're working with their primitive reflexes. So for those of you who don't know what primitive reflexes are, they're reflexes that we're born with, and they help us navigate the world. And they get integrated into the nervous system through free movement.
Yeah.
That's where the tongue restriction comes into place as well. If there's a tongue restriction, there is no free movement. There is movement, but it's dysfunctional. So we see babies that can only feed on one breast because it's difficult for them to turn the other way to the other breast. And we see babies that will prefer to sleep on one side, and then they get a flat head on one side because they're sleeping mainly on that side, and you turn them and they turn back onto that side. And then you see a lot of torticollis too. So the tongue, what a lot of people don't know is that the tongue is connected through the anteromedial chain of muscles through the entire midline of the body, all the way to the feet, to the big toe and to the fingertips. So when the tongue is restricted, it is like having to grow with an internal straitjacket.
Yeah.
And if that restriction of the tongue is not even on both sides of the frenulum, of that string under the tongue, then it means that it's pulling more one side than the other. And because it is connected all the way to the toes and the fingertips, having one side more restricted than the other means that there is a compensation running through an entire side. And often we see one shoulder higher than the other, one hip higher than the other. And then the compensations are not just on the side, but they're also back to front. The body will try and compensate to try and keep you mobile. But because the primitive reflexes are integrating through movement, we are seeing stages of child development being missed or being partially achieved. we have parents coming to us saying, my child was amazing. He went from sitting to walking. Very clever. It's actually missing a very important stage, which is integrating those cross primitive reflexes into the system. And when they're not integrating properly, especially the ATNR and the STNR, all of those cross-crawling movements that help integrate everything in the brain too, then we have lack of tone, we have lack of coordination, and we have issues with fine and gross motor skills too. If the rooting reflex, which is the reflex that helps us find our food when we are babies, touch and then the baby goes with the mouth open, if that one is not integrated properly, then we also have an open mouth posture. So the tongue connections through the entire body and the freedom of the tongue makes a huge difference to how we integrate those primitive reflexes. So we are seeing the same primitive reflexes are retained in tongue-restricted patients. They're the same ones, or they're almost the same ones as the ones that we find in ASD retained, and we see in ADHD also retained. So having a proper evaluation and eliminating things that could make a patient look like they have ADHD or ASD is really important. So we can come to a proper diagnosis of that patient, of that child.
And at the end of the therapy, what does that child, just for parents, what does that child end up being? You have you try to get to complete alignment or the right tongue posture to grow the right jaw so that they don't have to go through orthodontic treatments, to ensure that the roof of the mouth and the development and the posture of that child is actually the jaws coming out and is in alignment. Because I think you showed me there's this alignment with the forehead and the chin, which, fascinated me because I'm obviously looking at my own son. Yeah. Right. You've got to look for that.
If the chin is back, then you're not aligned with the rest of the face.
But it can be corrected.
Yeah.
It takes work, but it can.
Yeah. It takes work. It can be corrected. So if the child is under 2, we work with the primitive reflexes. If the child is between 2 and 7, we are playing games with them. So they're games. They're not called exercises, they're games. The brain learns better when we are having fun. And also those first 7 years is the height of brain plasticity. So we are recording the hardware of the brain functions that will be followed for the rest of the life. At 7 also, between 7 and 8 is where that suture on the palate, there is a flexible line in the palate that fuses around 7. So we have a chance to use the tongue to create space or open up the palate naturally. Past the age of 7, we're doing exercises. And if the arches are narrow, we need then an orthodontist to get involved. If they're reaching the age of 10, then most of the craniofacial growth is completed, over 93%. Now we're looking at correcting something that it's already been altered by the dysfunctional patterns. So rather than guiding the growth, we're now looking for how to correct this so it doesn't impact them long term. So towards the end of it, we're looking at how they're going to finish the therapy, but it very much depends on when they engage that process. Yeah. So if they are engaging after the age of 7, after the age of 10, we might need more intervention, including orthodontics. And then that elongates the treatment a little bit. But what we're trying to do is to stop that domino effect of dysfunction as soon as possible. And where we need to really ideally should be intervening is right at the beginning. Yeah. And then with adults, we treat also adults who have been diagnosed with ADHD at a later age as well, it's a little bit different, because now we're trying to manage their symptoms. We are not going to be completely eradicating the issues, because the craniofacial structure has already remodeled to that. But the body is a very clever machine. Bones are able to remodel despite the age, as long as there is life going through them. So we get remodeling of bones, even if you're fully grown. So the direction of the bone can change, and the shape of the bone can change. What we cannot do is guide the growth anymore, or make it grow long enough. And fibers and tissues also have the capability of remodeling according to the pressures we put on it. So we can still do a lot, and help patients at a later age too.
That gives a huge amount of hope to so many parents out there with a range of different ages of their children, and also adults. So I really do thank you, Yulli, for coming and joining me. And, I will be working with you, with my patients and also my son for the foreseeable future. And I appreciate what you're out there doing, because you're obviously changing lives, and all of these functions come in at the right, you need to do them at the right time for your child. And I know what impact you're having on lots of little lives. So thank you so much for joining me today on the Brain Development Podcast.
Thank you for having me. Thank you.